Good morning, everyone. Basically, this morning, I'm going to tell you a little bit about dental education. I don't have a PowerPoint because sometimes I think you listen better if you just talk. So this is an educational, informational session about what dental education knows. When I talk to dental education programs, you see a wide range of knowledge. You see basically from this much to this much. And in here, you've got the people who make a difference. And what we're trying to do at the ADEA is make that a lot of people who make a difference. So I'm going to share with you some of the things we talk about at the Dental Association. Now, I don't have a huge historical perspective. I don't have a lot of educational training in the area, and I don't have the knowledge of my fellow colleague. But I am pleased to be part of this illustrious panel, and I thank you for inviting me here today. The American Dental Education Association is considered the voice of U.S. dental education, and our mission is to lead and support the health professions community in preparing future-ready oral health professionals. So we are the dental institutions and the dental programs and the dental residency programs. We're not the practitioners. We're not the American Dental Association. The vision that our organization has is a well-prepared and diverse oral health workforce to improve the health of all individuals and communities. ADEA's emphasis on access, diversity, and inclusion involves identifying the importance of educating healthcare professionals and have them provide culturally competent, patient-centered care in humanistic environments. The effort is developing best practices for teaching and learning through a health equity lens. Racial and ethnic disparities exist in oral health. For example, in one study from 2011 to 2016, 70% of Mexican children aged 12 through 19 had cavities as compared to 24% of white children. Low-income adults had twice as many mild to moderate untreated caries and 3 times more severely treated cavities than middle-income adults. And American Indian preschool children have the highest level of tooth decay, more than 4% more times that of white children. The underlying cause of inequality have been suggested to be rooted in structural racism. Anti-racism practices and focus on social and political determinants of health, however, will not take care of everything. Lasting change comes from reimagining healthcare delivery and integrating medical and dental services and redesigning a reimbursement system. Technology should also be involved and for a collection and facilitate service assessment and a value-based healthcare delivery system. If you look at much of what we are doing right now, health disparities is defined as preventable differences in the burden of disease, injury, violence, and opportunities to achieve optimal health experience by socially disadvantaged populations. while health equity is thought of as being when every person has the opportunity to attain full potential, and no one is disadvantaged from achieving this potential because social position or other socially determined circumstances. When we've done this and bridged patient-centered care with cultural competence, we have better patient experiences, better workforce experiences, better clinical outcomes, and better economic models. Considering dental education's reach through technology-based resources, questions arise as to what is the definition of cultural competence, how social determinants of health impact health outcomes, how they vary across the globe, and how communication and language influences global interaction, and what's the benefit of culturally competent healthcare. There are over 3,814 distinct cultures described by anthropologists. So there is a reason that one might not have the ability to understand every single patient sitting in your dental chair. Cultural competence in healthcare is having the ability to provide care to patients with diverse backgrounds, as well as competence in their knowledge of, values, and belief in behaviors. Student education should include modeling by faculty in the areas of diversity and beliefs, values, language, along with patient needs and desires. This cannot be a one-stop shop, as we so like to provide. Professional health care bodies across the United States have standards. And these standards require graduates to be competent in managing a diverse and multicultural environment, as well as have a knowledge of health equity. And the dental standards are just some of those standards that you'll see across all health professions, as you know. However, to be honest with you, in dental education, I feel we're just starting to move this needle forward on these standards. Standard 2-16 in the dental world says graduates must be competent in managing a diverse patient population and have the interpersonal and communication skills to function successfully in a multicultural work environment. The intent of that statement is students should learn about factors and practices associated with disparities in health states among subpopulations, including but not limited to racial, ethnic, geographic, or socioeconomic group. That's it. That's basically what we see. When we look at the accreditation models, it's very easy to compile an event or a student project that meets the standard. I've been an accreditation site visitor. I've been on the commission. I've looked at what they do. However, in order to make real, lasting change occur, whatever the dental institution does, or dental education for that matter, it must be an ongoing, systematic introduction into the fabric of the institution's value center. The dental education models must change if they are to be the measures of accountability that dental programs fall into. Currently, it's piecemeal. But the need needs to be an entire review of all of the standards so that meaningful change can occur in the future. Partnering with our other dental professional organizations, I think this is going to happen in the very near future, so we are moving forward there. Dental education extends beyond any one country's borders. and it's imperative that collaboration among worldwide organizations occur to eradicate oral disease globally. But first, we as dental education educators must accept each other's value and then transfer that to our patients. Patient-centered care and cultural competence exist independently, but integration of the two and overlap of key elements ensure common ground between patient and the healthcare professional. An essential outcome is the development of culturally competent practitioners and implementation of culturally competent patient-centered care, resulting in transforming from health disparities to health equity. Oral health is linked to the overall health of the individual, but still nothing seems to focus on its total eradication, and it remains a major public health problem. Dental and oral disease nationally run rampant in communities that have limited access to health care. It is well known that most oral disease occurs in marginalized, underserved groups. Community health centers and dental clinics need to partner to integrate oral medical and behavior care. Preventive services and advocacy efforts to increase availability of those through policy changes are needed to achieve change and address the social determinants of health on all levels of the community, from the individual to the total. An example of a public health policy initiative in the past that significantly affected the oral health of the community was fluoridation. New policy initiatives need to occur in the area of increased dental benefits for the underserved. This would make a significant impact. For several years, interprofessional health education has been key to linking our professional health educational organizations. ADEA is involved with IPEC, the Interprofessional Education Collaborative, and is one of its founding members. Over the last 10 to 15 years, much work has been done on our competencies assessments, and also a broader understanding of the need for collaboration of the social mission has occurred. When I talk about our educational programs in schools, a lot of time and effort is focused on access to care and community access. Service is core to each of the schools, and we at the organization promote this. Clinical care in community settings, as you've probably heard from my colleagues, has been a hallmark of the dental curriculum for a long time. And the value is that not only providing the much needed dental care, but immersion into the community setting and attaining some sense of getting to know and understand the community and the value system of the patient. 35 years ago, I spent 2 months in a community setting, so it's been around for a long time. So regular rotations can be found in most dental schools and programs throughout the country. Along with this comes the health literacy component of the patient and establishing that knowledge bridge between the student and patient, which may be very low in many underserved areas. When I look at our organization's current status and where we are in helping our schools to understand these concepts, I see one that is growing little by little, but this year had a huge growth spurt. We just finished our annual meeting in person for the first time in 3 years. Diversity, equity, and inclusion programming could be seen throughout. Our organization will be 100 years old next year. However, at this meeting, I had a member tell me, crying, that this was the first year since she had been attending the meeting for 35 years that she felt that she belonged and her voice was resonating. A particular session that I would like to focus on was the President's Symposium on Men of Color in the Health Professions. Focusing on the huge underrepresentation of men of color in the health professions, panelists and the keynote speaker discussed strategies on how to move forward by partnering with other healthcare organizations to develop key initiatives in this area. But I'll be honest, this was not an easy sell to put this symposium on. Also, the organization was not silent the past 2 years over the many racially focused atrocities that occurred in our community, and internally put together a staff diversity, equity, and inclusion committee to represent and address staff needs and concerns during this difficult time, while externally providing resources to our member institutions. A new unit in our organization since I arrived 3 years ago is that of diversity, equity, and inclusion team, and the naming of our first Chief Diversity Officer. Our newest step forward is our climate survey, which has just been administered to all U.S. and Canadian dental schools and dental hygiene programs. The first of its kind for dental education, we hope to identify areas in which we can do better and implement strategies that can improve the organization throughout. And finally, deeply embedded in our strategic framework are goals that make us accountable in this area and measures. In addition, it's ADIA's job to serve as a repository source of educational curriculum and information for the educational institutions to draw upon when they need training and knowledge about these topics. We go to the schools, we provide the training, we provide educational resources. I've been to several. I've provided talks to foreign dental associations. It is important that the schools and programs be diverse themselves in order to emulate the diverse workforce of the oral health clinicians that will reflect the communities that they serve, both now and in the future. In closing, I hope that I've given you some semblance of where ADIA and dental education finds themselves currently. And from all interactions, I believe that we are moving forward, engaged, energized, and hopeful for change. Thank you.